Welcome to GatewayC Live, Greater Manchester. Fast facts, supporting earlier and faster cancer diagnosis.
Upper GI cancers. Think A to G. Our specialist is Dr. Mike Burkitt. A. Appetite loss.
Weight loss, abdominal pain and nausea, people with reduced appetite and particularly fatigue. There's a variety of different ways people present. I think nausea is one of the hardest to pick apart, but it's often quite important, particularly if it's linked in with weight loss. And those are all things that we do see in presentations, but can be quite difficult to pinpoint which way to go to investigate the patient.
B. Barrett's esophagus.
Essentially, what I think is important for Barrett's referrals are that you have where the last surveillance was done, so that if we do need to go looking for information, we can get it. And secondly, if it's available, the information from the previous endoscopy report and the histology. That's really critically important. And in terms of treating Barrett's, there's now evidence that PPIs are chemopreventative drugs against esophageal cancer in Barrett's esophagus. So people should be on high dose PPIs, usually twice a day, and they should be continued, and we shouldn't be stopping those drugs unless we've had a very good, careful think about it. So these are people who absolutely need long-term PPI use.
C. Check bloods.
It's useful to have a set of blood tests. There's a few reasons why blood tests are useful. Firstly, all these people may end up needing a CT scan, and I'm sure we're all aware that our radiology colleagues need a U&E before doing a CT scan for most people if they're going to have contrast, so it's always useful to have that. With these pathways, because we're trying to get people through the pathway as quickly and efficiently as possible, that's a really important sort of practical thing to get done. So I think knowing whether someone's anemic is really important, because obviously iron deficiency or B12 deficiency anemia in particular have links to upper GI pathology and can trigger a slightly different approach to the endoscopist.
D. Dyspepsia.
The commonest presentations that we see really are people who present with weight loss and dyspeptic symptoms, so heartburn or discomfort in the upper abdomen, and of course people who present with dysphagia, with food sticking in particular. One of the key things is weight loss. So people who've got weight loss and dyspepsia is important. And the other things that are important is to think about who your patient is. So if you've got an older patient with weight loss, that's much more concerning than when you have a younger person who is presenting with these sorts of symptoms. And it also, particularly in the young patient groups, it's important to think about how they respond when we initially treat them. So young people who have self-limiting dyspepsia or dyspepsia that gets better after a short course of acid suppression treatment, they're much lower risk, much less concerning. The people who are older and the people who are exhibiting other red flag symptoms, particularly the weight loss side of things, are much more concerning.
D. Dysphagia.
The presentations that we worry about are people who have food or drinks sticking and progressive problems over months or weeks are really high risk concerns. And we like to use the Edinburgh Dysphagia score to try to stratify that risk and decide whether people need 2-week wait investigations.
E. Endoscopy.
At Trafford, we've just started a NASE endoscopy service, and I know there are other NASE endoscopy services across the city that are being proposed or initiated soon. And that's the benefit of that service is that it is a less invasive endoscopic process. It uses a scope that's only 9 millimeters in diameter, so it's less invasive. It's not non-invasive, but it's less invasive. We get excellent pictures with it. We can see everything that we'd want to be able to see, and we can get people through pretty quickly. The other benefit for this is that it's a less aerosol generating procedure than a standard gastroscopy. So in time, though we haven't got to this stage yet, we hope to be able to increase the throughput of patients using that technique, and that hopefully will help us to recover from where we are at the moment, which is still with some delays in the endoscopy service.
F. Family history.
There are some very, very rare conditions where people have a single gene mutation that leads to familial gastric cancers. They're pretty catastrophic. They happen in young people, often in their 20s, and they get something called a diffuse gastric cancer that's really hard to survey and hard to avoid, really. There are some surgical procedures for it now to try to minimize the risk, but it's a real rare condition. What's much more common is that actually there are probably lots of small genetic changes that make it one individual's chance of developing a cancer much higher than another person. We understand some of that from a sort of research basis, but it's very difficult to translate that into clinical practice at the moment. And so we can't really alter people's management based on that.
G. Greater Manchester referral proforma.
Sarah and I spent some time just before COVID redesigning one of the forms for Greater Manchester, actually, to try to take into account the Edinburgh score. And whilst it doesn't ask GPs to calculate it, the idea behind that form is to try to understand the risk and try to be able to calculate that score when it comes straight into secondary care.
Think A to G. A. Appetite loss. B. Barrett's esophagus. C. Check bloods. D. Dyspepsia, dysphagia. E. Endoscopy. F. Family history. G. Greater Manchester referral proforma.
GatewayC Live, Greater Manchester. Fast facts, supporting earlier and faster cancer diagnosis.